TopMedTalk.
This is TopMedTalk, the broadcasting arm of EBPOM, evidence-based perioperative medicine. The EBPOM World Congress is taking place this year between the 7th and the 9th of July at the British Library in London. Check out ebpom.org now.
Hello, welcome to TopMedTalk. I'm Andy Cumpstey. I'm here at the anaesthesia research meeting in Birmingham, at the library in Birmingham, which has been a great couple of days. We've had some really interesting sessions already. The last session on drug allergy, some trial results, some really interesting things that I didn't know that I'm really looking forward to share with you at home. So without further ado, it's a real pleasure to introduce Dr. Louise Savic, who's a consultant anaesthetist in Leeds with a specialist interest in drug allergy and reactions, and Tom Abbott, who is a consultant anaesthetist at the Royal London and also a senior clinical lecturer at Queen Mary's University London. So Louise, Tom, welcome back to TopMedTalk.
Thanks.
So let's dive straight in. So you've just been talking to us about drug allergy and specifically labelling of drug allergies, Louise.
Absolutely.
To some people listening at home, that distinction might not be immediately obvious. What do we mean by a labelling of a drug allergy versus a true medical drug allergy?
Yeah. So what we know is that some people are truly allergic to a drug, and every time they meet it, they'll have an allergic type reaction. There's a far bigger proportion of patients who acquire a label of drug allergy when actually what they experienced was side effects or just unrelated signs or symptoms that were nothing to do with the drug that they took. To the best of our knowledge, that's probably around 90 to 95% of drug allergy labels.
Oh, wow, that high. Okay.
That data comes from penicillin allergy, which is the commonest allergy, not just in the UK or in surgical patients, but globally. So we know that when we test patients for penicillin allergy, about 90 to 95% of patients will tolerate it when it's given to them. But of course, there is that small but important minority of patients who do have a true allergy, and then it's really important that we do avoid the drug for those patients. So
it's a tricky area that you've become a bit of a national specialist in, but it's your PhD topic. It's a lot of your trial and research topics we're going to talk about in a second. But before we get into that, could you maybe tell us a bit more about the background to this work and why you became so interested in it and why it's such an important area for us to be looking at?
Yeah, absolutely. So I started to become interested in drug allergy maybe 10 or 15 years ago, and I was interested in perioperative allergic reactions. That's in a way a slightly it's a subgroup within drug allergy where patients can experience life-threatening allergic reactions. And when they're investigated after the event, certainly in Leeds and in lots of other centres, it's a multidisciplinary team that investigates these patients. And it's important to have anaesthetic input because we're able to read the chart and interpret it and understand what is unusual during that reaction and what other explanations there might be for the signs and symptoms that the patient experienced. So my interest in drug allergy started there, and I would say it's really fear of those life-threatening severe reactions that drives a lot of the behaviour around drug allergy and the application of labels that maybe don't reflect true allergy. It's that very understandable fear of true allergy. So I started in perioperative allergy, but then increasingly my clinical interest has evolved into, so I now see patients with any type of drug allergy, not just the perioperative setting. In the general drug allergy clinic, what I see is patients who come in who've been labelled as allergic to a drug for sometimes decades and experienced real or potential harm as a result of that label. And then when we test the label, more often than not, it was an incorrect label. So it's unnecessary harm. And really my research interest developed organically from that clinical interest that's quite tricky to solve. And one of the problems that we have with it that I think underpins all of this is that the tests that we have for drug allergy, we rely very heavily on the history of what happened. And then really still, even decades later, all we really have for most drugs is skin testing. And skin testing isn't 100% reliable. So what we end up having to do is to give patients test doses of drugs to confirm that they can tolerate them. So we don't have a nice, reliable, you dip the wee and you're either pregnant or you're not. We just don't have that really for drug allergy. And so that compounds the difficulties and I think compounds the problem of inaccurate labelling because it's not easy to test that label and get it taken off.
And Tom, so let's see how you got involved with this sort of work, but you've been involved, working with Louise on this now for a number of years, lots of research input. This is a really common problem that we see on an everyday basis. I'm sure it affects your practice too, but how did you sort of take that next step from seeing this every day to working with Louise on some of these projects?
Well, it was serendipity, really. We had been working on the Sapphire project for a number of years, and actually as a result of a Perioperative Medicine Clinical Trials Network Sampit Day in maybe 2016, we recognised that antimicrobial prescribing was a problem. Antimicrobial resistance particularly is a critical issue for healthcare in general. It's on the National Risk Register for the United Kingdom. It's a WHO priority for resolving, and yet the biggest driver of resistance is the use of antimicrobials, not only in healthcare, also in agriculture, but there is a lot of use of antimicrobials in healthcare which leads to resistance. Now, we undertook a systematic review which looked at lots of different studies that examined antimicrobial prescribing and administration in surgery. And obviously, there are over 300 million surgical procedures every year, many of which get an antimicrobial. And so there's a particular source of antimicrobial prescribing in surgery. And in that systematic review, we found that it's likely that giving less antimicrobials may not be harmful, suggesting that we could use fewer doses of antimicrobials in surgery to prevent infections routinely. However, to provide sufficient evidence to support that decision-making in the clinical environment requires a larger trial. And so as part of the early part of the Sapphire project, we tried to get an effectiveness trial funded to really see whether we could test a restrictive regime versus a usual care or more liberal regime, but we were unsuccessful. I started working with Louise when we were looking at the Sapphire as an observational study from my perspective to see whether we could assess if the number of doses of antimicrobials was associated with harms of antibiotic prescribing, particularly considering that lots of antimicrobial drugs carry harms, whether it's diarrhea, vomiting, tinnitus, vertigo, acute kidney injury, and allergy. And that's how Louise and I came into contact, because we felt that perhaps there were two symbiotic research questions that we could ask in the same cohort.
So it's really interesting, isn't it? It's not often we get one of these studies we talk about here on TopMedTalk where it's one trial, but actually with two sort of research questions, and they're clearly linked. But why don't you, Louise, maybe tell us a bit more about the sort of trial design and those two questions and why they work so closely together before we look into.
Absolutely. So, I mean, it's very efficient, isn't it? So it's a single data set with the same outcomes, the same cohort of patients, but the one question that's being answered is whether there's any difference between the numbers of doses of antimicrobials given for the same surgical procedure, and then using the same outcomes and patient cohort looking to see whether there's a difference in outcomes between those with allergy labels and without. So it was a multi-centre prospective cohort study. We used routinely collected data, so it was non-consenting, and then there was a 30-day follow-up period. Complications were graded using a Clavier-Dindo scale and by manual review of notes by trainees and other data collectors. We were in 21 hospitals and we had 370 or more data collectors, so it was a real team anaesthetic effort. It was only because of that we were able to collect such huge numbers, and then you can start to see real effect.
You mentioned it, but it's probably worth highlighting the very significant role that medical students and resident doctors, trainees, as formerly called, played in that role through the training networks.
I'm very grateful to them. And this really, some of the allergy work in Sapphire builds on a previous trainee-led study called Dales, which was delivered by the Raft Group, and we had, again, hundreds of resident doctors and medical students collecting data then too. So I think these studies are both testament to what can happen when anaesthetists get together.
So let's pick up with Dales first then, because quite rightly highlighting that's an important part of this background story, isn't it? So what did Dales show us, and how did that lead into Sapphire?
So Dales was, as I say, was a study run by the Raft Group, and in Dales we looked at 21,000 patients coming in on the day of surgery. So unlike Sapphire, it was all comers on the day of surgery, and we asked them, do you have a drug allergy label? And if they said yes, we had a very simple, essentially a set of screening questions just to try and tease out whether these were likely to be true allergies or not in enough detail to change management, but just for us to have an idea. And we also, as part of Dales, surveyed 5,000 anaesthetists, asking them questions about what their perceptions around drug allergy were and some of their prescribing behaviours. And then we were able to compare what anaesthetists said they did with what they actually did on the day of surgery, with some limited follow-up in patients who had either a penicillin allergy label or an opiate or non-steroidal allergy label. And in essence, what Dale's told us is that 29% of patients who come in for surgery have a drug allergy label, exactly the same figure that we found for Sapphire. 12% of patients will have a penicillin allergy label, which again, we've replicated exactly in Sapphire. And we were able to confirm, not with certainty, but with a reasonable degree of certainty, that around 60 to 65% of labels were likely to be wrong. And I would argue that it's probably even higher than that. That's just using the most conservative estimate. And when we followed those patients up, what we found is that patients have a penicillin allergy label, receive multiple broad spectrum antibiotics instead of penicillin, and occasionally they're given penicillin anyway, and occasionally they have anaphylaxis to the most commonly used alternative to penicillin, which is teicoplanin. So we had a signal that there's harm, but I really wanted to look at that in much, much more detail, which is, Sapphire's really now given us that really granular understanding about outcomes.
So just to emphasise those numbers again, because I think they're quite astounding for people that may not have heard this data before. But so essentially 1 in 3 of our patients have one of these labels. And then
it's awkwardly between 1 in 3 and 1 in 4. So
almost,
it's tricky.
And then almost 2/3 of those labels are wrong and are causing harm.
So the evidence from Sapphire would suggest that even when you adjust for all the covariates that we know increase your risk of complications, so being older, being sicker, having diabetes, frailty, even adjusting for all of those, you have a much higher instance of post-operative complications. So as far as we can tell, the presence of a label is associated with substantially increased risk of post-operative complications.
Really interesting. But I think it's also probably worth just highlighting that increase in comorbidities was also higher in the group with the label, from what you said.
Absolutely. So, and in that sense, Sapphire, again, reflects lots of data that's out there. So people pick up drug allergy labels when they have interaction with healthcare, and they're given medicines. And every time you are given a medicine, there's an opportunity for you to potentially have an allergic reaction, or much more likely experience side effects which are mislabeled as allergy. So older and more comorbid people have had more opportunities to go through that process and collect drug allergy labels. So we expect to see more drug allergy labels in older and more comorbid patients. But in Sapphire, what's interesting is even when you adjust for age and comorbidity, that effect still persists.
So it seems, at least from the statistics that we've got so far, that there's a definite association between having the drug label and more harm in the patient.
Yeah, absolutely.
So I guess the next obvious question, and maybe Tom can know this as well, but what do we do about that? What's the next stage, and how should we take that information back into our practice?
I mean, I'm going to defer back to Louise as the allergy expert for this when speaking about what to do next with the allergy labels, and certainly your work so far has looked in some detail at this, Louise.
Yeah, so testing patients and taking them off is a process called delabeling. And most, if not all, of the evidence for that really comes from penicillin. Again, commonest label, it's out there, 12% of the surgical population have it. But there are difficulties with this. So in an ideal world, I suppose everybody who picks up any drug allergy label will go to a specialist clinic, meet someone like me, be tested and have their label taken off, and that's the end of it. But the difficulty in the UK, and not just in the UK, but globally, is that simply aren't enough allergy specialists. So we think there are probably around 5 or 6 million people in the UK with a drug allergy label, or at least one drug allergy label. And we have about 140 drug allergy specialists. So we just don't have, it's a tidal wave. And I think that tidal wave is getting bigger and bigger all the time, possibly driven by perception of safety, and, the healthcare safety is a huge driver. I think e-prescribing is probably part of that as well. So in recent years, there's been a big focus on whether some patients, selected low-risk patients, could have their delabeling, their testing and delabeling done outside of a specialist allergy clinic. And I think that is a direction of travel we have to go in. But I think we need quite a lot more research to understand how to do that safely and effectively.
And you presented some quite compelling data on that in your talk. I don't know if you could maybe just summarise that a little bit for some of the listeners at home.
So I ran a study 2 years ago with an immunologist in Birmingham called Thirumala Krishna, and we ran a study called the SPACE study, which looked at the feasibility of non-allergist delabeling. And that's been published if anyone wants to look at it. But in essence, we showed that it is feasible. People who don't have specialist expertise can be trained, and that's a pathway that people can go into. But the limitations that we found are that a very high proportion of patients are not willing to take part in delabeling and or may not be medically suitable to undergo delabeling. They didn't meet our study criteria, and our study criteria broadly match clinical criteria that we use in clinic. So it may not be as straightforward as we would like it to be. Like all these things, it's probably a lot harder and more complex than we'd hoped. And certainly a few years ago, I thought this should be more straightforward to do than it has turned out to be.
And you mentioned the patients there, but I was going to ask you about that. What do the patients think about some of this work when you say to them in your allergy clinic with that specialist allergy hat on that actually, although you've been told for many, many years, 20, 30, 40 years in some cases, that you're allergic to penicillin, I'm now telling you you're not?
Yeah, so I suppose it's hard to judge in a way, a bit like some of the efficacy studies around delabeling. The people who come to clinic for testing are a self-selected group of people who'd like to be tested for their penicillin allergy label. And often they've been the ones to drive that referral and ask for it, or they've spoken to their GP. The GP's explained this is probably not a true label. You may be better off if you go and have it taken off. So they come already primed. What we don't know is about all the other hundreds of thousands of people out there who may say, I would never go and be tested and I have no interest at all. So I'm not sure my experience in clinic is necessarily reflective. We do have the SPACE study. We also have the Alabama study run by John Sando, who's a microbiologist in Leeds. That was the first RCT of delabeling in the UK. It's a really great study, and it showed that when you take these labels off, people do go on to receive appropriate penicillin treatment when they next need it. But again, it can be hard to recruit patients into it and to get patient buy-in. And there's another problem as well, which is that what we found in Dales, and in some respects, this was the main finding for me, when we surveyed anaesthetists, we surveyed about 5,000, it's about a third of practicing anaesthetists, and we gave them a hypothetical, this is an anonymous survey, we gave them a hypothetical scenario of a patient who comes to you who needs penicillin for surgery, but the label's been taken off. Would you give them penicillin for their operation? And 52% of anaesthetists said they would still avoid penicillin in that scenario. So there is a very persistent anxiety.
So as you said in the talk very eloquently, these labels are very sticky.
Very sticky. They are the Japanese knotweed of healthcare.
You're going to have to explain that analogy for our listeners at home.
So in the talk I was talking about Japanese knotweed introduced as a pretty ornamental bush, but it actually just completely takes over and ruins your entire garden and undermines all of the sort of structural foundations of your garden. And it's impossible to get rid of. And I think that's what drug allergy labels are in healthcare.
So every time I see a penicillin allergy now in the ward, I'm thinking of Japanese knotweed, which is, there we go. But so what...
perhaps that's a good thing.
I was going to say, but so maybe that's what I should be doing. So how do we take this to the next step? Should I be trying to delabel every patient I see who says I've got a penicillin allergy, or should I be referring that to the small proportion of allergy experts that we don't have and they're going to get overwhelmed by the service?
It's tricky, isn't it? I mean, as a clinician, I come across patients with allergies all the time. I'm aware that perhaps the practice that I'm engaging in by giving an alternative could be harmful, but I think it's very difficult to go against an entire team in that clinical setting to say, no, actually, we're going to do something different.
Yeah.
Because everything is so protocolized, and it's not just the medical team, it's the whole MDT. Everybody has to be on message in order to achieve that, and I think that's a struggle.
It's really difficult. I can speak in terms of capacity for testing. The direction of travel is that we need hub and spoke models where you have a regional allergy centre that can provide training and ongoing support for centres outside that already exists in some trusts in the UK. The model that we need moving forward, and I think it needs to move from what it sometimes is at the moment with enthusiasts who are trying to drive a service, but to become sustainable, we will need long-term funding, and this needs to be recognised as a substantial problem. But unfortunately, without funding, that is extremely difficult to achieve.
So funding's always the,
Yeah.
But taking that not so small, insignificant hurdle aside, what are the next stages? I mean, so you've clearly, both of you, got a huge amount of data here in Sapphire still to look at. There's the other research question, which we haven't really touched on in a huge amount, but that's obviously going to be looked at in detail as well.
We obviously had a lot of patients in the Sapphire study. We included 13,646 in our analysis. We found that around 1 in 5 patients in that cohort developed a complication, which is very consistent with other data in this space. We found that around 1 in 10 patients developed some form of side effects of antimicrobials. Our primary analysis was an exposure of a number of doses of antimicrobial, and the outcome was surgical site infection. We did not find an association between those two. We had a very high uptake of surgical prophylaxis in the Sapphire study. Around 97% of patients got antibiotics for prophylaxis. What we did find is that there is some signal, as the number of doses increases, the harms associated with antibiotic prophylaxis increase as well. And that is consistent with the other literature. And so it was good to see that we sort of saw that result. What it means is that we may want to look to future trials of whether we can actually reduce the amount of antibiotics that we're giving for prophylaxis. I was talking to some colleagues before this meeting, and it's not just a UK problem, it's a global health problem, particularly in the global south, where antimicrobials are used even more so than in the UK. There's an enormous potential for harm. And so I would see this as not just a UK issue, but a global problem.
Absolutely.
And from the allergy side?
Yeah, I mean, it's exactly the same. It's a global problem. And I think penicillin allergy labels in particular are even more common in the global south. I don't think we have great data about that, but there's a strong signal towards that. If all of those patients are then turning up for surgery and having worse outcomes, that's just an amplifier of an existing harm.
Well, thank you very much for A, sharing all that data with us, and B, joining us here on TopMedTalk. Really excited to see how this story develops over the coming months and years. I think there's a huge amount of work still to do here, but really exciting times, and can't wait to see how this story progresses from both aspects. Thank you.
Thanks, Andy.
Thank you.
As always, you can hear this episode and every other episode on our website, through our app, or through your podcatcher of choice. TopMedTalk's on all the main social media channels. If you do find us in any of those, Facebook, Instagram, LinkedIn, Blue Sky, please do hit like, hit subscribe. It really makes a difference to us at this end. And as always, thank you to our fantastic sponsors who keep us free and open access around the world. And for this year, that's BD, Advanced Patient Monitoring, and GE Healthcare. Thank you.
TopMedTalk.
TopMedTalk is the broadcasting arm of EdPOM, evidence-based perioperative medicine. Join clinicians from around the world at EdPOM World Congress 2026 between the 7th and the 9th of July at the British Library in London. 3 days of evidence-based perioperative medicine, global insights and expert debate, featuring speakers including Michael Marmot and Ken Rockwood. Go now to edpom.org. That's edpom.org.